last talk is by Dr. Ravi Kumar.
Good morning, respected chairpersons, convener, and my society members and audience. I'm Dr. Ravi Kumar, and I'm going to talk on the Bruch's membrane opening minimum rim width. It's a new horizon in glaucoma diagnostic. I have no financial interest to disclose. So, glaucoma is a neurodegenerative disease characterized by accelerated retinal ganglion cell death leading to progressive visual field loss. It is estimated that 30% to 50% of retinal ganglion cells are lost before visual field defects can be confirmed by our standard visual field testings, and therefore early detection of glaucomatous neuronal loss is critical in the diagnosis of the disease and maintenance of the vision of our patients. So although there is a general agreement about the utility of the OCT in diagnosing and following glaucoma, there is a debate as to which best parameter is useful and is better to measure. The circumpapillary retinal fiber layer thickness was among the first OCT measures of the glaucomatous damage. More recently, Chauhan and colleagues have argued for a more anatomically and geometrically accurate measure of the neuroretinal rim, that is a measure that they have called Bruch's membrane opening minimum rim width. So what's a Bruch's membrane opening? It's a pentalaminar structure composed of retinal pigment epithelium basement membrane, inner collagenous layer, middle elastic layer, outer collagenous layer, and the choroidal endothelial cell basement membrane. The innermost edge of the Bruch's membrane, known as the Bruch's membrane opening, has been shown to have clinical and diagnostic value for glaucoma, and this structure is easily visualized by the SD-OCT. So this is the picture showing the Bruch's membrane opening at the ends of the border of tissue of the Elsning, and the second picture is showing the minimum rim width, which is extending from the Bruch's membrane opening to the inner limiting membrane. So the BMO identifies the anatomic position of the disc margin more accurately and consistently than the traditional techniques that rely on the subjective appearance of the optic nerve head surface. The BMO is stable over time in both healthy and glaucomatous eyes, making it a valuable reference point for other eye structures. From the BMO, new indices have been introduced, such as BMO MRW, which is defined as the minimum distance from the BMO to ILM. And some studies suggest that the BMO MRW is a better predictor of visual field total deviation and visual sensitivity threshold than the retinal nerve fiber layer thickness in patients with glaucoma. In contrast, other studies have found that the diagnostic accuracy of BMO MRW is similar to RNFL thickness for differentiating between the healthy and glaucoma eyes. More recent studies, however, have suggested that the best method will involve some combination of these two parameters, the RNFL and the BMO MRW. So Nazia Uzar et al. Have reported BMO MRW is better indicator of glaucomatous damage in moderately myopic eyes as compared to the OCT RNFL, and she et al. Have reported longitudinal RNFL OCT measurements are more likely to detect structural changes than BMO MRW in moderate to advanced glaucoma damage. So in macro disc, BMO MRW has the best diagnostic power to discriminate glaucoma patients from the normal control compared to the RNFL thickness and rim area in CSLT. And BMO is significantly and positively correlated with the axial length and negatively with the age of the patient. So what is the impact of the optic nerve head size and corneal curvature on the BMO MRW? The circle diameter of 3.4 mm is the most accurate and reproducible scan for the measurement. Using fixed scan diameter without adjusting one edge sizes reduces the measurement of accuracy. So thus the spectralis has the glaucoma module premium edition, accounts for the size of the optic nerve head defined as the BMO area, and it compares each eye BMO MRW with the reference database. So magnification is determined by two factors, axial length and the corneal curvature. So progress analysis. Assessment of progressive changes in the optic disc and RNFL is based on the event analysis or the trend analysis. Event-based analysis detects progression when a follow-up measurement exceeds a pre-established threshold for change from the baseline, and trend-based analysis detects progression by evaluating the slope of the measured parameter over time. So progression is commonly defined by trend-based analysis when significant negative slope is detected using linear regression analysis. So what are the pitfalls of this measurement? So it has got floor effect. Due to the presence of residual tissue, that is the glial cells, blood vessels, and non-functioning ganglion cell axons, or failure of the tissue segmentation of algorithm, it has got artifactual floor. And there is a red and green disease also. So red disease is a false positive diagnosis where the software mistakenly identifies an eye as abnormal even though there is no glaucomatous damage. And green disease is a false negative diagnosis when the software interprets actual glaucomatous damage as normal. And there are some patient-related factors like split bundle of the optic nerve head, myopia, peripapillary atrophy, media opacity, vitreoretinal interface problems, peripapillary vitreoretinal traction, ERM, and peripapillary atenoschisis. Optic nerve head pathologies and pupil size and motion artifact will also impact the BMO measurement. And blink artifact and mirror artifact, these are the OCT factors which will cause error. And the later are the instrument factors, the operator factors, and incorrect axial alignment of the OCT. These are my references. So BMO is a new parameter which is yet to be discovered, is unexplored. So measure what is measurable and make measurable what is not is the thought of Galileo Galilei. Thank you.
So this BMO, as you rightly said, is a newer thing which is coming up. Again, the measurements which are very practical and easy, especially with the Heidelberg spectralis. Otherwise, even the Zeiss also works, but it's not that Heidelberg gives an easier mode to measure it. The only problem is with the whatever correlations have been done with the refractive errors and having a basic database, like we were initially also, we are still stuck because most of these machines are being developed for Caucasians. So having an Indian data, which is still lacking, there are studies going on. There are people doing studies all across India also on this, on measuring the basic thing in the normal population. And then having it for different types of refractive errors is also very important before we actually start using that in glaucoma patients. So that is one thing which we need to start analyzing and start, maybe more and more centers who are doing work on glaucoma need to have a baseline for their own centers. Yeah, maybe for that particular set of people, like South India separately, North India separately, and that is how to define.
So any question or comment from the audience?
Sir, sometimes like in early glaucoma suspects, when there will be no RNFL losses, but BMO will be showing thinning, the minimum rim width. In that patients, we can think that later on, these people will develop. With like in glaucoma suspects with high risk, we can. Yes, sir. This is the issue. This is. Yes,
so for
yes.
progression, it might be helpful, as you're rightly saying, for progression, it might be helpful, but right now, till we have our own normative database, whether saying whether this person is going to be a suspect or is going to go from a suspect to a glaucoma is still not, is still the future, actually the future.
So I think as we are advancing towards technology, we are trying to detect earlier and earlier changes. So this is one of those processes where, you know, we are looking at maybe these changes are starting much earlier and we are able to pick up with these machines, but yet to be established when we have a longitudinal data that, you know, ultimately these patients only are converting to glaucoma. So it is still, I think, at that stage where we can have documentation when we are following up a glaucoma suspect to understand, you know, whether these patients are actually developing. So I think all these tools are, as you know, our resolution is improving and imaging techniques are improving, we are able to detect much more changes, many of which may be false positives also. I have my serious doubts, but I think this is the way forward, where we can, you know, look in hindsight also that whether these patients are developing glaucoma and these patients are getting normal. That is how we will, you know, have our imaging biomarkers which can detect glaucoma much earlier than when we see at RNFL changes and GCC changes.
Let's have an open mind.
Yeah, that's what I would say. So excellent presentation. Thank you so much.